Assalamu alaikum wa rahmatullahi wa barakatuh, everyone. I'm AbdulRahman Farahat, a fourth-year medical student, and welcome to the CVP Pharmacology crash course. So for this crash course, it's a little different. We'll be going through questions, but after each sort of lecture or topic, we'll be reviewing the whole concept together, inshallah. If you're watching this as a recording, you could skip over those parts and just solve the questions, whatever suits you best. Right. So let us begin with our first question. A 53-year-old man post-MI is on metoprolol and low-dose aspirin, presents for follow-up. He quit smoking after the MI. Exam shows obesity of 100 kilograms and 178 centimeters. The labs show a total cholesterol of 155, HDL of 27, and triglycerides of 92. Which lipid-lowering agent is most effective for preventing future cardiovascular events? Direct question, hopefully. The answers could get a little confusing. Okay. Okay. So the answer is C. I've got a lot of C's and A's. The answer would be C, which is statins. What is a statin? It's an HMG CoA reductase inhibitor. HMG is the rate-limiting enzyme. We're going to talk more about it. A would be an absorption inhibitor, cholesterol absorption inhibitors like ezetimibe. B would be a cationic exchange resin, which is like bile acid sequestrants. Then you have essential fatty acids. What would that be? Omega-3. Omega-3, pharmacological vitamins, that's niacin, and transcription factor ligand will be fibrates. We're going to talk about them now. But this is for question one. Question two. A 33-year-old man with hyperlipidemia was prescribed a drug to reduce his plasma lipid levels. After taking the drug for 2 months, he presents with myalgia and high creatinine levels. Which drug causes these adverse effects? B, perfect. Yeah. So this one is, again, a direct question. It's more about the adverse effects of statins. And the reason I put this question here is because of this. Really, you need to memorize it and be very good with it, because Dr. Hatouf could generally ask you about anything over here. She could go from myalgias, rhabdomyolysis, eye opacity, and renal dysfunction. I remember she asked us once about it, I think last year. But it could go anywhere. Try to be really good with these adverse effects. We can't directly what? DM. Yeah, Saraha, I don't know what's happening with Zoom now. Like this question 4. A patient is prescribed a cholestyramine along with digoxin. What is the most likely effect of this drug interaction? Perfect, mumtaz. All right, you guys got this. D, which is reduce absorption of digoxin. And our final question is a 57-year-old man with a history of severe hypertriglyceridemia and prior fibrate intolerance presents after acute pancreatitis. Labs show severely elevated triglycerides. Liver and pancreatic enzymes are normal. He's prescribed a medication likely to cause flushing and warmth. Which agent mediates these side effects? Okay. C, prostaglandin. Be good with this one as well. Yes, I saw it at the end of your slides. The doctor spoke about how niacin could cause the flushing and warmth. Be good with it as well, because it could get asked about. Dr. Hatouf, again, anything could go. طيب. Let's review lipid-lowering drugs in general. Why do we give lipid-lowering drugs? Because you have high cholesterol or triglycerides in your blood, صح? Niacin stimulates the release of prostaglandins, and this causes the flushing and warmth that you get. We'll go through it, inshallah, as well. طيب. So again, lipid-lowering drugs. Why do you give them? Because you have high cholesterol in your blood, high triglycerides. Okay, if I'm trying to lower it and avoid any cardiovascular events such as coronary artery diseases, any atherosclerotic plaques, whether could cause strokes, PVDs, or whatever. Right? I want you guys to tell me, there are two pathways where you could get cholesterol or lipids in your blood. What are they? Dietary intake, صح? And the endogenous synthesis of your body. Which one is more common or produces the most cholesterol? No, that would be the endogenous synthesis, actually. So the dietary intake accounts for about 20 to 30%, while endogenous synthesis, your body, your liver creates cholesterol, which is around 70 to 80% of your body cholesterol. So if you just think about it right now, what is the drug, or how do you want to fight this cholesterol or elevated cholesterol levels? You need to close off which pathway? The endogenous synthesis. So if you block the endogenous synthesis pathway, you're good to go. And what drug does this? This is the basis of a very important drug. Statins. Yes, HMG-CoAs. Perfect. So over here, you can see, again, a very basic physiology-heavy diagram. We'll go through it really quickly. Here, let's start from the diet. Over here, you get your dietary cholesterol. It goes through your gut. You have the release of bile acids from your liver. It breaks down or forms the micelles and allows you to absorb the cholesterol into your enterocytes or your intestinal cells. They start forming your chylomicrons, which is essentially cholesterol surrounded by a lot of triglycerides. And very important to remember, there is an apolipoprotein because those lipids are not soluble in your blood. So they need an apolipoprotein to surround them so that they are more soluble in the blood. So they get surrounded by an apolipoprotein B48 for chylomicrons, and for VLDLs, you have B100, if I'm not mistaken. But over here, you can see that the chylomicron gets broken down using a lipoprotein lipase. I can't see the top of the screen. Yeah, so I wrote it. A lipoprotein lipase that breaks down the chylomicron. It breaks down the triglycerides around the chylomicron, and it releases free fatty acids and gives you a chylomicron remnant. This chylomicron remnant, along with other free cholesterol in your blood, gets absorbed by your liver through an LDL receptor, and they start forming your cholesterol. This cholesterol is half of it goes for bile acids, others are used for the body through this pattern. So you can see it goes through bile acids and into the gut, or goes as a VLDL and released back to the blood, where they get used by other parts of your body. So this is, again, very simplistic diagram. It is going to lead the discussion into our drugs. So our lipid-lowering drugs act on one of those steps over here. So if you understand this well, we could move on. Is this good? Mumtaz. But let's start with the drugs that target your dietary intake. You have two main drugs, the cholesterol absorption inhibitors and your bile acid sequesters. For cholesterol absorption inhibitors, from their name, you know what happens. They go into the gut. They prevent cholesterol from getting absorbed. Simple as that, easy to meet. Then same thing with bile acid sequestrants. Where do we need bile acid sequestrants? Again, over here, bile acid binds to cholesterol and prevents their reabsorption. Now, for adverse effects, really quickly, for cholesterol absorption inhibitors, what do you guys know? There's a single adverse effect that comes to mind, which is hepatic insufficiency, or hepatotoxicity, could cause hepatic insufficiency. The only thing you need to remember about ezetimibe, very low yield drug, probably will never get asked about. Bile acid sequestrants, you have cholestyramine and cholinesterase. Adverse effects, steatorrhea, okay, because you're losing fat. Perfect. This is what I want. The fat-soluble vitamins, and then certain drugs. Remember the question we just solved. Because cholestyramine is a bile acid sequestrant, you have bile acid does not only bind cholesterol, it binds to a lot of other substances, and it allows your the absorption of those substances. Of those substances, you have your vitamins. Which vitamins? Your fat-soluble vitamins, A, D, E, and K. So if you are not absorbing those, if you're not absorbing bile back into your body, you're not absorbing those vitamins either. So you'd have vitamin deficiency. One other thing are the drugs, which we already said, digoxin, two more, warfarin, and one more, thyroid hormone. So yeah, this is for the dietary intake drugs. If I'm going too fast, you guys can let me know, come on. Now onto the endogenous synthesis, and you guys should be amazing at this. You have statins, and you know what it does. It prevents or blocks off your HMG-CoA reductase inhibitors. I'm going fast? Okay, sorry. So statins, they break down your HMG-CoA reductase, or they inhibit your HMG-CoA reductase, which is your rate-limiting enzyme. This enzyme basically takes all your body molecules and turns them into cholesterol. So if you stop this enzyme, you stop forming cholesterol. And this is your endogenous synthesis. And you guys know about their adverse effects. I showed you a question about it. H for hepatotoxicity, M for muscles, so myalgia, rhabdomyolysis, and stuff. G is for gut issues. CoA, so Co is for, could be contraindicated in pregnancy, could cause cataracts, and A, renal dysfunction. Did I miss anything? Let's go back. I think. Perfect. Okay. So yeah, the adverse effects of statins. Okay. Now I want to ask you guys about some pharmacokinetics regarding statins. Where do statins get broken down in your body or metabolized? In your liver. Okay, so you have a cytochrome P450 in your liver. Perfect. Like, let's say you have a patient who has a hepatic insufficiency, their liver is not functioning that well, and you need to start them on a lipid-lowering drug. And the question specifies that it is a statin. What statin can you give in this scenario? Pravastatin. Perfect. Why is pravastatin? It is not metabolized by cytochrome P450, and it is really excreted by the kidneys, by the renal pathways. Tamam? This is why you could give pravastatin. Right. Next drug you have is adenosine triphosphate lyase inhibitors. Those are also called, if you memorize that name, good for you. If you memorize ACL, you're amazing. You have bempedoic acid. ACL, where is ACL located? What comes to mind when you think of ACL? An ACL tear, صح? In your knees. So what are the adverse effects? Hyperuricemia could cause gout. Gout happens in your joints, صح? What else? Muscle pain, cause tendinitis, صح? But all of those musculoskeletal, it causes lower back pain. All of those musculoskeletal things are related to its name, ACL. Very low yield. You probably never get acid. But moving on to our final list of drugs, which are the miscellaneous drugs. You have the PCSK9 inhibitors, microsomal, whatever that was, fibrates, niacin, and omega-3. For PCSK9 inhibitors, okay, so I have this diagram to explain how PCSK9 works. Basically, you have, this is the blood. This is the LDL receptor over here. Can you guys see my mouse? Laser pointer. So yeah, wow. Yeah, exactly. So it inhibits LDL recycle. So what happens is PCSK9, it binds to the LDL receptor. This is the normal situation, okay? You still didn't give the drug. It binds to the LDL receptor, it engulfs it, and inside the cell, it breaks it down. Then what happens? You give them the PCSK9 inhibitors as an injection, and it is a monoclonal antibody against PCSK9. So you don't have this PCSK9. So now the LDL receptors remain on this surface, and they are able to engulf in LDLs from your body. This is how PCSK9 works. Right. So remember, alirocumab and evolocumab. If we want to talk about adverse effects, I already told you it is given as an injection. So how could you relate that? Nasopharyngitis is one. Hypersensitivity, perfect. So hypersensitive, remember 3 types of reactions. Hypersensitivity reaction, because it's given as an injection, so injection site reaction, and it could cause an upper respiratory tract infection, okay? And then as you correctly said, nasopharyngitis, you could also say nausea and vomiting and diarrhea, those are basic stuff. Like, then you have your macrosomal triglyceride transfer protein inhibitors, zometipide. Okay, how does that work? Do you guys remember when we spoke about how the LDLs, or your body cholesterol in general, they are surrounded by an apolipoprotein, صح? So over here, it's like, You can see that they are surrounded by an apolipoprotein. Now, what lomatipide does is it prevents the formation of those apolipoproteins. So basically, those structures are unable to get into the blood. They stay inside the cell. Perfect. Adverse effect, there's really only one that should come to mind, which is hepatotoxicity. Like fibrates, this is kind of high yield, could get asked about. Fenofibrate and gemfibrate. How do they work? They work by yes, perfect. So this is the correct answer. Because a lot of people say they simulate lipoprotein lipase, which is correct. However, you need to mention the transcription factor, which could get asked about. You need to understand that PPAR itself might not be asked about, but understanding the concept that fibrates stimulate a transcription factor, that really leads to the upregulation of lipoprotein lipase. This is the whole concept of fibrates. And what does lipoprotein lipase do? Breaks down your chylomicrons or your triglycerides into free fatty acids, which causes an increase in HDL. Perfect. This is the second high yield thing you need to remember. There's only generally two main drugs over here that on this list that could increase HDL. Fibrates, and the second one is niacin. Perfect. Type. What is the adverse effects of fibrates? You need to remember one. Should not be given with. You can't give fibrates with what? With statins. Why? Because they could exacerbate muscle pain, myalgias, all those. Tamam? So this is the main adverse effects of fibrates. Like niacin. Niacin already sort of touched upon. Their mechanism of action is all over the place, to be honest. I've seen a couple of sources, but I wasn't clear on one. However, all you need to know about niacin is one thing, which we already mentioned. It increases your levels of HDL. And the second thing is the adverse effect, which is flushing. And how do you deal with flushing? 30 minutes before. Mumtaz. Finally, you have omega-3 fatty acids. Very unnecessary. The only thing that you'll probably get asked about regarding omega-3 fatty acids is their adverse effect. One specific adverse effect, which is fishy aftertaste. There is a fishy aftertaste. Fishy smell or fishy aftertaste. It will be mentioned in your question prompt. So I've done this. Yeah, and this is, by the way, the mechanism of how you might ask fibrates increase the level of HDL. So what is HDL? Generally, HDL is a high cholesterol and low triglycerides around. And what do fibrates do again? They break down your triglyceride. So imagine they start with something like this. They break down the surrounding triglycerides and do nothing to the cholesterol. And at the end of the day, you get an HDL. Side effect again for fibrates is the muscle pain. You need to remember muscle pain for fibrates. Also, it could cause something in your liver, in your gallbladder. It's also very high yield to remember. Gallstones, perfect. It will always be mentioned. Yeah, could cause, I think it was mentioned in one of the questions. It could cause gallstones. So over here, again, summary of everything we said. And we could move on to our next section. Is this one done? Simple? Perfect. Moving on. We have a 64-year-old man with diabetes, peripheral artery disease, and exertional angina, develops chest pain and ECG changes on exercise stress testing. He started on aspirin, but develops wheezing and shortness of breath. What is the best alternative therapy for secondary cardiovascular prevention? B, perfect. Clopidogrel. And why? All the other answers are basically not antiplatelets. It's really good at its job. That's as well. Clopidogrel is the only antiplatelet among the answers. Everything else is an anticoagulant. We'll talk about them now. Moving on. A 69-year-old man with exertional chest tightness, hyperlipidemia, and diabetes is prescribed a nitrate that relieves symptoms by forming whatever this is in vascular smooth muscle. Which part of the cardiovascular system is most affected by this drug? Okay, so this question is, again, kind of high yield. No. Yes. So yes, the answer is C, large veins. Nitrates, I'll speak about it now, but remember nitrates, their most action is on the veins. So they cause venodilation, and this is why C is the correct one. Tamam? We'll talk about those as well. Actually, we could discuss them now. A is for what affects your cardiac muscle. You could think more about beta blockers. What affects your large arteries? Could be calcium channel blockers, could be hydralazine. You need to differentiate between arteriolar dilation and venodilation, and we'll talk about them now, inshallah. Right. Next question. A 76-year-old man with diabetes presents with severe chest pain and ST elevations and needs 1 AVL V5 V6. He receives aspirin, nitroglycerin, and fibrinolytic therapy. Hours later, he becomes comatose with asymmetric pupils and irregular breathing. Yes, okay, perfect. So the answer is D, intracerebral hemorrhage, and this is because fibrinolytic side effects, and you can see asymmetrical pupils, irregular breathing. These are all signs of neurovascular issue. Side question, what part of the heart is affected from these leads? Let's see if you guys study. Lateral leads. ممتاز. طيب. A 55-year-old man with exertional chest pain relieved by rest is prescribed sublingual nitroglycerin. This drug relieves symptoms by causing which hemodynamic change? Okay. So yeah, the answer to this question is B, which is a decrease in left ventricular end diastolic volume. And this comes back to the discussion we already had regarding how nitrates work on your veins and they cause venodilation. And when you have venodilation, you have less preload. So less blood is going back to your heart. And so you're reducing the amount of diastolic volume in your heart. Tamam? طيب. So now let's go on to the lecture itself regarding antiplatelets, anticoagulants, and all of those, and the anti-anginal drugs. So starting with the antiplatelets, let's take a look over here. You have, this is the endothelium of a blood vessel. Over here is the basement membrane. You get some sort of injury, and that is taken away. And then on your basement membrane, what comes? Your von Willebrand factor. Again, it's first-year stuff. However, we're reviewing it all so that it makes a full idea. Now, so von Willebrand factor comes from your basement membrane, and then your platelets come and bind to it using this factor over here, which is glycoprotein 1b. Hello? Are we good till here? This is the first step of platelets, which is platelet adhesion. Hello? After that, what happens? Once the platelet get activated, through this binding of von Willebrand factor with the glycoprotein 1b, they start releasing a lot of stuff. From those stuff is the thromboxane A2 and your ADP and ADP. So thromboxane A2, what does it do? Causes two main things. Vasoconstriction is one, and number two, it causes what? A lot of platelets to come. Tamam? It calls for other platelets. And the ADP has another action. The ADP acts on the other platelets, and it causes the stimulation or release or expression, better to say, of glycoprotein 2b or 3a. And so this way, the other platelets could bind with the platelet plaque over here using glycoprotein 2b, 3a interaction. حلو. So 3 steps: adhesion, activation, aggregation. ممتاز. طيب. So now for the antiplatelet therapy, you have 6 drugs. Okay, so last step, what happened is, Allahumma salli Muhammad, you got your von Willebrand factor. Okay, خلاص, your platelets are activated. They release those 3, thromboxane A2. It's okay, don't worry. Thromboxane A2 and ADP. Okay, thromboxane A2 causes vasoconstriction. This is the normal situation. You're trying to maintain a blood loss. تمام. فplatelets go and cover the affected area. But you release thromboxane A2 causes vasoconstriction, and it calls for other platelets to come. Then you have ADP, which binds or stimulates those platelets to express what? Glycoprotein 2B or 3A. And this way, once they express it, they could bind together. The platelets start building on top of each other and cover the area. Tamam? So now we move on to our antiplatelets. So you have aspirin. How does aspirin work? Mechanism of action? COX inhibitor, tamam. And what does it do exactly as a COX inhibitor? It inhibits the release of a certain thing we already spoke about, which is thromboxane A2. Perfect. This way, you don't have thromboxane A2, you don't have the platelets aggregating on each other. Hello. طيب, do you give low dose or high dose? Low dose. Why not high dose? Okay. So for side effects, generally, high dose inhibits other pathways. One of them is the prostacyclin path. Prostacyclin called it. Okay, let's not get into it. But it could cause worse effects, worse side effects. Right. So this is for aspirin. Then you have clopidogrel and prasugrel. How do they work? Their mechanism of action? ADP inhibitor. So where does ADP come from? Here. Huh? Lowers your cyclic AMP level. I found questions regarding this. The MCQ mentioned that what is the mechanism of action of ADP, and it causes decreased cyclic AMP. So decreased cyclic AMP causes your expression of glycoprotein 2B3A. So if you think about it this way, clopidogrel causes decreased or increased cyclic AMP? Increases cyclic AMP. So now you don't have your glycoprotein 2B or 3As. ممتاز. So inhibits aggregation. Perfect. Adverse effects. Generally, adverse effects for all those antiplatelets, you have to think about one thing, which is bleeding. Okay. And one specific for clopidogrel. Neutropenia. Perfect. Type. And then you have prasugrel, which is more potent, clopidogrel, prasugrel. Prasugrel. Type. Glycoprotein 2B and 3A inhibitor. Again, very simple. They are monoclonal antibodies against those glycoproteins. Then you have dipyramidol. This is a phosphodiesterase inhibitor. What does phosphodiesterase do? So yeah, the inhibitor increases cyclic AMP. Phosphodiesterase itself breaks down cyclic AMP. Exactly. So it breaks it down. So if you're inhibiting phosphodiesterase, you're increasing your cyclic AMP, and so you're preventing glycoprotein 2B or 3. Like, one thing you need to remember regarding dipyramidol is its indication. It's not typically used for coronary artery diseases. It's typically used for prophylaxis for those that have emboli on their prosthetic valves. So I'm sure you guys took infective endocarditis and stuff. You know that sometimes those patients could have a prosthetic valve, and you could have emboli forming over them. So dipyramidol is given in that case as a prophylaxis. Secondly, as prophylaxis to strokes as well. That's correct. The last one I don't want to mention because it's the most low yield drug ever, protease activated receptor. It's called vorapaxan or something, vorapaxapar, yeah, that thing. It's really unnecessary. The mechanism of action is a single thing. Really quickly, what is it? Thrombin. Yeah, PAR1, which inhibits thrombin platelet activation. main thrombin receptor. Yeah, that one. Very unnecessary. You'll probably not get asked. Right. That's it. Yeah, that's it. You want more? Aspirin, adverse effects, صراحة, you probably won't get asked about. The main adverse effects I could think about regarding aspirin is stuff like Rey syndrome. You could have allergic reactions or an immune reaction, like the case we already had, where he had shortness of breath and stuff after giving aspirin. Right, so this is for antiplatelets. Let's go into anticoagulants. So for anticoagulants, you have to remember two things. Parenteral or oral intake. So parenteral is like IV or any other part of the body, oral from the mouth. Okay? Like for parenteral, you have heparin and low molecular weight heparin. How does heparin work? I have this lovely coagulation cascade over here. Again, first year stuff. You don't need to remember any of this reading. I want you to focus with me on it inhibits antithrombin 3. Perfect. So how does that happen? This section over here. You see factor 10 gets converted to factor 10A. And with the help of factor 5, it converts prothrombin to thrombin, which is factor 2 to factor 2A. Where does heparin come into this? Again, forget about heparin now. Antithrombin 3 actually comes, and its main action is it inactivates thrombin and factor 10. So this is antithrombin 3, the normal action of it. Heparin comes and stimulates antithrombin 3. So it accelerates its activity. So now you don't have factor 10A, you don't have thrombin either. Okay? This is for heparin. What's the difference between heparin and low molecular weight heparin? Okay. So over here, normal body. Okay, normal body. You have when you have a break in your when you have the activation of your coagulation cascade and you need to block methane bleeding, you have factor 10 gets converted to factor 10A over here. This section over here. Factor 10 gets converted to factor 10A, and this causes the formation or the breakdown of prothrombin to thrombin, and it activates. Okay, so now your thrombin is activated and could cause a clot, could block a clot. Tamam? So now you have antithrombin 3. What it does is it inactivates thrombin and factor 10A. This is the normal activity of antithrombin 3. Goes and inactivates thrombin, so it causes you to bleed. It does not form a clot. Hell, are you good till here? So heparin comes and it stimulates antithrombin 3, or it accelerates its activity. So essentially, you're again preventing the clot from forming, and it increases your blood fluidity. This is heparin. Now, my question was how to differentiate no factor 10 or factor 5 or factor 2. Now, what's the difference between low molecular weight and heparin? Low molecular weight doesn't inhibit both thrombin, since it's not large. Yeah, which is better because that decreases systemic. So yeah, you're basically correct, which is low molecular weight heparin does not. So for preventing the clot from forming, heparin needs to bind to both thrombin and antithrombin for inhibition. So over here, heparin needs to bind to antithrombin and thrombin to prevent this activation. Right. So for low molecular weight, it's smaller. So it does not bind thrombin. It only inactivates factor 10A. Okay? So it only acts on factor 10A. Like you said, low molecular weight only inhibits factor 10A. But when it comes to adverse effects, what are the adverse effects that you should think of regarding heparin? There's many. Bleeding, of course, can't go wrong. Ulcers, hit, yes. So heparin-induced thrombocytopenia, perfect. I think you guys will take hit more in your heme lectures, so I won't discuss it now. But remember that it could cause thrombocytopenia. And the last thing is hypersensitivity. Like you get a patient and you see that they have hit, for example, after taking heparin. What is your antidote? something sulfate, which is protamine sulfate. Okay, protamine sulfate. Right. Now this is for heparin. Moving on to oral drugs. You have warfarin, rivaroxaban, and dabigatran. Right. So for warfarin, how does it work? Inhibits K, vitamin K, yes. So it inhibits vitamin K epoxide reductase, an enzyme. Yeah, so over here, normal function again, your liver converts factor 2, factor 7, factor 9, and factor 10 using vitamin K into active forms, and they could go into the blood and form a blood clot. Now, vitamin K, after it goes through this step, it gets consumed, صح? But you have this amazing enzyme called vitamin K epoxide reductase, and it converts back the inactive vitamin K into an active vitamin K, and it could go again through another cycle and provide more factors 2, 7, 9, and 10. So what warfarin does is it comes and it blocks off your vitamin K epoxide reductase. صراحة, I doubt you'll get asked about the factors. No. But it's good to مثلا understand which like PTINR or APTT you should follow. FND vibes, yeah, it is. But you'll probably not get asked. So yeah, these I forgot where I stopped. So for vitamin K, it again gets activated and causes formation of the active factors. Warfarin stops this cycle and prevents the factor 2, 7, 9, and 8. Now, something you need to remember is for chronic anticoagulation. So if you're giving it for a long term, which would you use? Heparin or warfarin? Warfarin, صح? But if the patient presents acutely with coronary artery disease, would you start them in warfarin and expect it to work? No. صح? Why? Because those patients or those people, they already have active factors running in their blood. They already have it active. So you give them warfarin and expect it to work for later factors. Heparin is more acutely given. It acts on the sudden, the exact situation you're giving it at. For adverse effects, for warfarin, what are they? Again, bleeding. Okay, warfarin has a narrow therapeutic index, correct? It's teratogenic. Necrosis. So it causes something very important called warfarin necrosis. And then there's also one more thing, osteoporosis. So remember 3 things: bleeding, osteoporosis, and warfarin necrosis. Okay? Type. We spoke about this. Yes, warfarin drug interactions, this could be asked about as well. So you have certain drugs that increase the effect of warfarin, which are amiodarone and sulfonamide. And you have other drugs that could decrease the effect of warfarin, such as carbamazepine and rifampicin. So you could get it as a question. You have a patient who's a known coronary artery disease patient, and they were given rifampicin, and all of a sudden, he presents acutely with sudden chest pain. What is the cause of the sudden chest pain? Because the warfarin is not working anymore. Is warfarin good? So infarction happens, yeah. Type. What can you see over here? Warfarin necrosis. Perfect. Type. And the last 2 drugs are rivaroxaban and dabigatran. All you need to know about them is their mechanism of actions. You could know about their indications. So let's go first with mechanism of action. Rivaroxaban is a factor 10A inhibitor, and dabigatran antithrombin, factor 2. Indications, it was mentioned rivaroxaban could be used for a Fib, in case it doesn't work with other drugs. But finally, onto fibrinolytics. So you have the formation of a fibrin clot over here. So how does the body act by breaking down your fibrin clot? Through this plasma. And where does plasmin come from? It comes from plasminogen that gets broken down by TPA, tissue plasminogen activator, and gives you plasmin. Plasmin breaks down your fibrin clot. Perfect. So you have 3 drugs for that. You have streptokinase, altiplase, and tensityplase. طيب. What's the benefit of using مثلا streptokinase? Over the others? It has a short half-life. Streptokinase has a very short half-life. But why is it bad? There's a couple of things. So streptokinase antigenic effect. So it comes from what? From a bacteria. Strep pyogenes. It comes from that bacteria. And so if that patient has been already infected with that bacteria, so they have antibodies. If you give them streptokinase, they have antibodies against streptokinase. And so it causes an antigenic effect. But one other thing is, okay, so let's go to altiplase. So for altiplase, why is it better than streptokinase? Lacks the antigenic effect. And then it is more clot specific. So it affects the clots, yeah, fibrin specific or clot specific, less systemic, exactly. That's about it for those. Again, if you think about, we had a question about their adverse effects, which cause intracerebral hemorrhage. It's a very common, targeted question regarding how it causes hemorrhage or bleeding in the brain, especially. So intracerebral hemorrhage should not be given for stroke patients, all of those. Yes. So contraindications is what? If someone has an active bleed, whatever in the body. So, moving on to anti-anginal medications. So angina, you have chest pain because of stenotic coronary artery. The drugs you have are nitrates. You have either nitroglycerin, and we already mentioned how it decreases your preloads. So what was decreasing preload? You're decreasing blood going back to the heart. Mumtaz. It acts more on the veins, causes venous dilation. 2, you have beta blockers. How do beta blockers work? What do they do? Okay, so it binds to beta receptors and they block them. What comes after that? So beta 1 receptors on the heart, they usually, they stimulate your contraction. And so beta blockers prevent that stimulation of contraction. It makes your heart weaker. And this what reduces oxygen requirements for the heart. Right? Secondly, you have calcium channel blockers. You have 2 types, DHP and non-DHP. Okay, so what does DHP calcium channel blockers do? From its name, D starts, so DHP causes vasodilation, okay? Non-DHP calcium channel blockers act on the heart, and they do the exact same thing. They reduce your contractility, and they reduce your heart rate. Yeah, target smooth muscle vasodilation. Examples, do you guys know examples of DHP calcium channel blockers? Nifedipine. Okay, and non-DHP, you have 2. Verapamil and diltiazem. Type. Now, potassium channel openers, this is a newly introduced medication, which is nicorandil. And by thinking about it, it opens your potassium channels. And so what happens? You have less depolarization, or the heart does not contract as much because it's in a hyperpolarized state. There's more potassium going on. That causes what? Again, it reduces the heart rate. Now, one thing about nicorandil as well, it acts on your blood vessels and it causes dilation. Again, because there is no, it is in a hyperpolarized state. So ivabradine, I already have the mechanism of action over here. It reduces the amount of funny current channels. Do you know where the funny current channels are? AV and SA node, which phase? Phase 4. So as it rises, you have less funny current, so it will take longer to rise. I'll show you guys the action potentials now. Trimetazidine, I doubt you guys will get asked about. It basically switches from fatty acid oxidation to glucose oxidation. So what does this mean? Why is this better if you switch from fatty acid to glucose? More ATP. Glucose produces more ATP than fatty acids. Breaking down fatty acid does not produce as much ATP. Finally, you have ranolazine, which acts on late sodium channel. And over here, I sort of showed it, like this diagram. Imagine at the plateau phase, so the myocardial infarction goes, or the action potential goes up, and it's at the plateau phase, tamam. You have a lot of entry of calcium, صح? And calcium maintains this contraction of the heart during that position. So normally what happens is you have sodium going in, and then sodium gets inside the cell and gets exchanged with calcium. Help? Now, ranolazine, what it does is it stops this sodium from going in, and basically you won't have any more calcium inside the myocardium itself. And so now your heart will not stay in the plateau phase or contracted for a long period. It will rest fast. تمام؟ So this is for anti-anginal drugs. Main point to take over here is the venodilation for nitrates, because that question could get asked. طيب. We're done with the anti-anginal drugs and your antiplatelets, anticoagulants, and our fibrinolytic drugs. Is this good? All good. ممتاز. All right. Let's move on to hypertension. One of the best pulmonary drugs, easy, very much easier. We won't stay as long in the pulmonary drugs, inshallah. We could take a break, مثلا, let's say we finish before arrhythmias, like one more lecture, and we could take a break and then do all together. Right. Question 10. 6-year-old man with hypertension develops a dry cough after starting lisinopril. His medication is switched to losartan with good compliance and no side effects, compared with no treatment. What change is expected with his current therapy? Fine. Let's break it down. What is, tables are. What is lisinopril? Aro? Yeah, it's an ACE inhibitor. So he was started on lisinopril and then he was switched to losartan. Why? Because probably the dry cough and stuff. Dry cough because of bradykinin. So losartan is an Arab. So what is an Arab? Angiotensin receptor blocker. So would it bind? It would bind to the receptor. What would happen to the levels of renin if there is no action? Increase. What would happen to the levels of angiotensin 1? Increase. Angiotensin 2? Increase. So you'll have the levels of angiotensin and the RAS in your blood, they just won't act. So aldosterone is down. Why is aldosterone down? Because what does angiotensin do? It causes increased aldosterone. So now you stopped the angiotensin from increasing your aldosterone because you have an angiotensin receptor blocker. And so aldosterone levels will go down as well. Finally, to the bradykinin, no effect. صح? Because you're comparing it with no treatment. Let's say if you're comparing it with lisinopril, what would happen in bradykinin levels? Increase or decrease? Do Arabs increase or decrease the bradykinin levels? Yes, so the bradykinin levels are high in ACE inhibitors. This is why you have your dry cough. So in Arabs, you'd have low bradykins, exactly, and you wouldn't have the dry cough. Right. So this question clear. Did I confuse you guys? Okay. Right. Question 11. A 77-year-old man with newly diagnosed hypertension is started on medication. 3 weeks later, his blood pressure improves, but he develops bilateral pitting leg edema. Creatinine and urine analysis are normal. Which antihypertensive was most likely prescribed? They cause ankle swelling. This is what type of what drug class? Calcium channel blockers, exactly. DHP or non-DHP? DHP. Right, perfect. Moving on. A 52-year-old man with hypertension begins taking a new antihypertensive agent that is expected to enhance natriuresis while also causing a sustained decrease in serum angiotensin II concentration and aldosterone production. The effect of this medication are most similar to which of the following drug classes? I saw a B. Yes, aliskiren is a renin inhibitor. صح? So a renin inhibitor would decrease the serum angiotensin II concentration. This is the key word to this one. An angiotensin II receptor blocker would have this level as high. صح? طيب. Now, for antihypertensive, this is the whole gist of antihypertensive drugs. تمام? You need to think about three things. You're either reducing your cardiac output, you're dilating your vessels, or reducing your volume. حلو? Three things. Yeah, this slide is from the doctor's slides, actually. So reducing cardiac output, you have two ways. We already spoke about them, beta blockers and calcium channel blockers. So how do they work? They reduce the heart rate, the contractility, and everything. And as I focus over here, the non-DHP calcium channel blocker. So if I give you guys this action potential, where do each work? Is this a beta blocker or calcium channel blocker, the one on the left? Na. Okay, so let's review the action potentials really quickly. So over here, what happens at the beginning phase? You have funny currents, صح? Sodium would start coming in. تمام? Then you have this upstroke. What comes in over here? Calcium. So calcium causes this upstroke. And then it drops back by opening of potassium channels. Okay? So after I said that, which drug is over here? You have this prolonged phase, phase 4. No, it's a beta blocker. So over here, the beta blocker acts on phase 4. It delays phase 4 and slows your action potential. Where does calcium come in? Where does calcium start coming in? This upstroke, huh? This is where calcium starts coming in. So if it is a calcium channel blocker, this upstroke should be prolonged, like over here. You have a prolonged calcium. Tamam? So on the left, you have the beta blocker, and on the right, you have the calcium channel blockers, the action potential with a calcium channel blocker. And over here, you have the action potential with a beta blocker. Maybe I should have put the antiarrhythmic drugs at the beginning. I could have explained the action potentials. We're going to come to the action potentials later when we explain the antiarrhythmics. But okay, so you need to understand how action potentials in the heart work to get a good idea of. You could get asked about how the graph will change depending on which drug is taken. So for beta blockers, it acts on phase 4. You have this prolonged phase, all right? And then you have a normal action potential. For calcium channel blockers, it affects your calcium channels. Calcium channels start opening over here in the upstroke. Normally it is steep, صح? It's steep like this. But with calcium blockers, it starts swaying more. Tamam? This is for non-DHP calcium channel blockers. Type. Let's take a look at the adverse effects, because I don't think I mentioned them in the previous one. So adverse effects for non-DHP calcium channel blockers. We just had a question on. We had on the DHP actually. Yeah. So remember, it causes this, you can see slowing of the SA node, صح? So it causes what? Cardio depression. Yeah, these are for DHP, correct. Like edema, flushing, and headache, all of those are for DHP. For non-DHP, because they don't act on the blood vessels, they act on the heart itself. Because what? Heart failure, they could cause cardio depression, constipation. Remember constipation for calcium channel blockers. And for both, you could get gingival hyperplasia. Type. And for DHP, like we said, flushing, headache, and edema. Type beta blockers, adverse effects. Okay, for non-DHP, you have constipation, heart failure, and cardio depression. Because it slows down your heart. Somehow, we have heart failure, cardio depression, slows down your heart. For DHP, you have what? Like you said, edema. For beta blockers, bradycardia. So heart failure or heart block, bradycardia, bronchoconstriction. Perfect. What's one thing you should be careful of with beta blockers? Asthma. So yeah, you shouldn't give it to COPD patients or asthma. For withdrawal, you need to be you should be careful with abrupt withdrawal symptoms. You should take your ischemic heart disease. Yeah, you should taper it off, exactly. Or you should not remove or stop beta blockers suddenly, because it could cause reflex tachycardia, could cause worsening of the symptoms in general. Right. So let's go back to this one over here. You have the reduced cardiac output we've dealt with. You have dilate resistant VES. Tamam? You have multiple ways we could go through this. We already spoke about your calcium channel blockers and how they prevent calcium entry. And so your blood vessels, they dilate. Then you have the renin-angiotensin system blockers. So over here, you can see how the normal body works. You have angiotensinogen, gets converted to angiotensin 1 using renin. Angiotensin 1 is converted to angiotensin 2 in the heart because of ACE enzyme. And then the angiotensin 2 acts on their specific receptors. It causes increased aldosterone and it causes vasoconstriction. This is the normal body again. So now you give them an angiotensin or an ACE inhibitor. What does ACE inhibitor do? Prevents formation of angiotensin 2 and prevents breakdown of bradykinin. So now you don't have angiotensin 2, so you won't have the vasoconstriction, you'll have vasodilation, and you won't have the aldosterone. So you'll be excreting or releasing more urine. And for bradykinin, like you know, the adverse effects. Type. For the adverse effects of ACE inhibitors, what are they? Cough, hyperkalemia. Okay, I'll give you guys a mnemonic you could use to remember the ACE inhibitors, the Arabs, and the REN. So use the mnemonic catch, okay? C for cough, A for angioedema, T is teratogenicity, C is creatinine, high levels of creatinine, H is hyperkalemia, another H is hypotension, okay? So this is for ACE inhibitors. Let's say you have Arabs. What are the adverse effects of Arabs? The exact same thing, by the way, except the first two, cough and angioedema. So remember, and then last one is renin inhibitors. You'll have exactly the same except only cough. H. Is this simple for you guys to remember? Perfect. Yeah. Going back to this, so we spoke about calcium channel blockers, the RAS, and then you have alpha-1 adrenoreceptor blockers. From its name, what do alpha-1 receptors do? Where are they found first? They are found in your blood vessels. So, and what do? Alpha-1 receptors, not the blockers, the receptors. Good question. Vasoconstriction. So you have a blood vessel, you have alpha receptors on the endothelial cells. No norepinephrine or any sympathetic neurotransmitter gets released. It binds to the alpha-1 and causes vasoconstriction. So vasoconstriction worsens your hypertension. So if I want to vasodilate, how do you vasodilate? You give a blocker, an alpha-1 blocker. So do I have the yes over here? You have an alpha blocker, such as phenoxybenzamine, phentolamine, or you have prazosin and doxazosin. Type something else is methyl dopa. What is methyl dopa? Mechanism of action. Pregnancy. Yes, that's before that. An alpha-2 agonist. So if you look at this diagram over here, alpha-1 is on the postsynaptic left. So alpha-2 is on the pre. And what happens in the pre is that it causes negative feedback. So it prevents, the release of epinephrine and norepinephrine. And so you don't have epinephrine and norepinephrine, and the blood vessel dilates as well. Like you rightly mentioned, it is used in hypertensive pregnant lady. Okay? It's not usually given alone as well. Yes, exactly, with nifedipine. Or it's not always with nifedipine, but it's could be given with other drugs as well. So for alpha blockers, let's go back to that. We mentioned how it causes vasodilation. Now I need you guys to remember one main adverse effect with alpha blockers, which is orthostatic hypotension. It causes a severe drop in blood pressure, because imagine all your blood vessels starts vasodilating, all your blood starts falling down. Severe orthostatic hypotension, and it is most severe on first dose. So first dose orthostatic hypotension. Finally, you have mixed blockers. What is it about nifedipine? Okay, so for mixed blockers, they block both alpha and beta. They act on both alpha and beta. And I had a question I forgot to add, but it was how labetalol could slow down your heart rate, and it could cause also vasodilation. So I remember labetalol. Now, one other thing you need to remember about labetalol is that it is the drug of choice, actually, pregnancy. It is the drug of choice for hypertensive emergencies in pregnancy. Labetalol. I'll give you a mnemonic now to remember the drugs used for pregnancy. It's called New Moms Love Hugs. So nu is nifedipine, MUMS is for methyl dopa, LOVE is for labetalol, HUGS is for hydralazine. Those 4 drugs are for hypertensive emergencies in pregnancy. Yep, nifedipine, methyl dopa, labetalol, and hydralazine. Right. Now, moving on, you have certain, so let's go back to our diagram over here. We spoke about calcium channel blockers. We spoke about RAS. We spoke about alpha-2. Now on to vasodilators. Hell, so for vasodilators, you need to remember 3 main drugs, or 4, which are minoxidil and diazoxide. Mechanism of action, very low yield, by the way. You'll never get asked about this. Probably, if you could get asked about something, maybe minoxidil, but diazoxide you'll never get asked about. What? No. Nitric oxide. Okay. Mechanism of action. Let's go back to the mechanism of action of minoxidil. How does it work? It opens potassium channels. Yeah. An ATP sensitive potassium channels. So when you open potassium channels, you're causing hyperpolarization. And this eventually causes vasodilation. Because the polarization causes, or depolarization causes the contraction, hyperpolarization causes vasodilation. But then we have sodium nitroprusside. Oh, actually, minoxidil has one other use, by the way. Hirsutism, for hair, exactly. But sodium nitroprusside. Let's go back to this. Mechanism of action, it causes vasodilation, nitric oxide. You already mentioned this. Perfect. So this is what I wanted to focus on. Cyanide causes cyanide poison or cyanide toxicity because it could be broken down into cyanide. But finally, you have hydralazine. Okay, so over here you can see hydralazine causes vasodilation in arterioles. It's the exact same thing, by the way. Hydralazine causes vasodilation, nitric oxide, using the arterioles. So remember, we spoke about 3 drugs. We spoke about nitric oxide. It causes vasodilation in what? Veins, arteries, arterioles. Veins. Then you have sodium nitroprusside. It works on both equally. So it vasodilates both veins and arteries equally. And then you have hydralazine, which works on what? Arteries. Yes, I was going to come to the side effects. The only thing you need to remember regarding side effects of hydralazine is drug-induced lupus. ممتاز? طيب. Okay, going back to our lovely slide over here. خلاص, we're done with the cardiac output, the dilated blood vessels. Yes, so I was going to mention to you guys the direct Coombs test positive for hemolytic anemia in methyl dopa, but I doubt you'll get asked about, so I did not mention it. Right. Coming back to this one, all we are missing right now are the lovely diuretics, and we have 3 types of diuretics. Okay, so let's start with thiazide diuretic. Okay, they ask you low yield, يعني حرام صراحة. The questions I included in those slides are probably, and inshallah, they won't exit from those questions, inshallah. Right, so coming back, diuretics, they work on the distal convoluted tubule by doing what? What channel do they inhibit? Inhibit sodium chloride channel, distal convoluted tubule. Adverse effects, I have a mnemonic for you, hypergluc. So you just add 2 hypo, which is hypokalemia and hyponatremia, and then hypergluc. Hyper, G for glycemia, hyper L for lipidemia, hyper U for uricemia, and hyper C for calcemia. Gout, hypokalemia, hyponatremia, hyperglycemia. Okay, so you're missing lipidemia. Right, so this is for thiazide diuretics. For loop diuretics, okay, let's go to the mechanism of action. Yes, so sodium, potassium, 2-chloride in the thick ascending lens. Drug name, furosemide. Adverse effects, you said ototoxicity. Again, I have a mnemonic for that, which is ODANG. I'll show it to you guys in a sec. Finally, you have the potassium sparing diuretics. Drug name. And extracellular fluid depletion is very important in loop diuretics, by the way. Extracellular fluid depletion, we're going to talk about it now. It's very important. So spironolactone, mechanism of action, it inhibits aldosterone receptors in your cortical collecting tubule. Adverse effects, hyperkalemia and gynecomastia. So over here, yes. So over here, you have all the diuretics with their adverse effects. You can see thiazide diuretics, hypergluc and 2 hypos. You have, potassium sparing, the last one. And then loop diuretics, you have ODANG, which is ototoxicity, hypokalemia, hypomagnesemia, dehydration. This is very important to remember with loop diuretics because they cause extracellular fluid depletion, like you rightly mentioned. Then you have allergy, metabolic alkalosis, nephritis, and gout. ODANG. And then finally, you have potassium sparing diuretics. Did you guys not take potassium sparing? You took it, but in a different lecture. I added it to the diuretics because they are all diuretics altogether, but you took it in heart failure lectures. It's in the heart failure lecture, exactly. We're going to come to that as well. For loop diuretics, if you have to really remember something, remember ototoxicity, remember dehydration. Dehydration is very important because it causes extracellular fluid depletion. And this is why it's one of the main drugs used for heart failure, because it causes a lot of diuresis. Again, you can see gout here is related to hyperuricemia. They're very closely related drugs. Simple mnemonic to remember all their adverse effects in general. But can we, خلاص, this is done with hypertension. Are we good with hypertension?
Yes, I wanted to ask, there was one drug that also causes gout, except other than loop diuretics. What was it again? Can you remember?
So we spoke about a lot of drugs. In lipid-lowering drugs, you have the ACLs, cause hyperuricemia. Remember the citrate lyase inhibitors? Thiazides could cause hyperuricemia. Sarah, it's going to be hard for me to remember all the drugs right now. You could. The one that came to me right now is the ACL inhibitors and the lipid-lowering drugs, first section. So now let me ask you a little about, let's test your hypertension drugs. For primary hypertension, your first-line medication. Give me first-line medications for primary hypertension. Beta, not really first-line. Thiazides. Thiazides is a first-line. Arabs and ACE inhibitors, those are also first lines. But remember, beta block, thiazides, ACE inhibitors, Arabs, all of those are first line. Like, let's say you have a patient who has diabetes mellitus and hypertension, of course. What will you give them? Arabs or ACE inhibitors. Those are the main ones that could come to mind. Why exactly those? Because Arabs and ACE, they protect, they are protective against diabetic neuropathy or nephropathy, not nephropathy. So they are protective of your kidneys. Right, let's say you have a patient, okay, pregnancy, we already spoke about new moms, love hacks. Okay, I think we could move to our next slide. So yeah, over here, you have everything listed. طبعا, I doubt you guys should know it ideally, but you won't be tested to this extent, inshallah. Just try to remember for diabetes mellitus, again, ACE. For primary, thiazide and ACE. For asthma, of course, you have to be careful with beta blockers, like you said. And hypertension in pregnancies, new moms, love hacks. Simple stuff, huh? Okay, can we move on? Class, everything good? Next lecture, Bismillah. A 67-year-old man with non-ischemic cardiomyopathy and left ventricular ejection fraction of 30%, has persistent dyspnea on exertion despite multi-drug therapy. Blood pressure is 115/70, pulse is 66, S3 is present, mild edema. Which diuretic would improve survival? D. Did you guys take mannitol? No. C. One of you said the right answer. It is E. Spironolactone. What is spironolactone? A potassium-sparing drug. Okay, so the key word in this question is which diuretic would improve survival. So this patient has heart failure. You guys need to remember 3 main drugs that protect your heart, or they improve survival in heart failure patients. You guys know them, the 3 main drugs. So one of them is potassium sparing. We agreed on that. What are the other 2? ACE inhibitors or ARBs? No, ACE inhibitors or ARBs? Beta blockers. So 3 drugs. ACE, try to remember A, B, and the last one is just an imposter, like spironolactone. But A is ACE inhibitors, B is beta blockers, and then aldosterone or potassium sparing diuretics. Good? Remember them really well. This is actually very high yield. And the key word, as you can see over here, which drug or which diuretic improves survival? I have a slide on it. I'll show it to you guys in a bit, inshallah. Right. Moving on, we have a 54-year-old man with non-ischemic cardiomyopathy and recurrent decompensated heart failure, and he started on digox. 3 weeks later, he feels improved. Which initial cellular event explains this benefit? Yani you're close. You're technically not wrong, because it is the end result. But the key word over here is initial cellular event. What's the first thing digoxin does? It decreases sodium efflux. So what does digoxin do? Sodium potassium ATPase, so it inhibits sodium from exiting the cell. So yeah, so it is A. The key word in this question is initial cellular event. Yes. So if I ask you what is the end result, your answer will be correct. It does increase intracellular calcium. But since I asked initial cellular event, you need to go back to the origin, the first thing that happens, which is sodium potassium ATPase. Right. Question 15. A 67-year-old female comes to the clinic complaining of fatigue and exertional dyspnea. On examination, she is afebrile, has bilateral lower extremity edema, and hepatomegaly. Jugular venous distension is visible. This patient started on valsartan. Okay, you guys got this. Neprilysin inhibitor. What does neprilysin do? Breaks down atrial natriuretic or brain natriuretic. So now a neprilysin inhibitor would prevent the breakdown and increases atrial natriuretic. Perfect. Right. So now for drugs in heart failure. Going over the concept of heart failure really quickly. Yeah, it increases endogenous natriuretic peptides. So going over the concept of cardiac failure. So you have cardiac injury. Your heart is not pumping enough blood. It's weak. It's not doing its job. But the body does not know that. The body just understands, and wallah, I'm not getting enough blood. So what it does is it increases its sympathetic activity, it activates the RAS system. All of those would eventually lead to vasoconstriction, and the heart itself is not able to pump. And you're increasing vasoconstriction, so now the heart is pumping against even more pressure. So this will increase the cardiac injury, and the heart will fail more. So now you need drugs. You need to find a balance between reducing this vasoconstriction while at the same time you want the heart to start pumping. You want this balance between pumping and reducing the pressure. So is this simple for heart failure? Drugs for heart failure, we spoke about furosemide. We spoke about the vasodilators. So furosemide, it relieves the volume overload, because now you're reducing the pressure in the blood vessels. And so if you're more volume loss equals less pressure in your blood vessels, and so the heart could put more effort. But vasodilators, again, you have vasoconstriction, you have a lot of pressure, you give them vasodilator to relieve that pressure. So this is why you have arteriolar such as hydralazine and venous such as nitrates. We're done with this one as well. You have the RAS system blockers, done with. Beta blockers, we said they reduce the heart activity. Now, beta blockers are contraindicated when you have acute decompensated heart failure, which is basically when the heart stops pumping. If the heart is no longer pumping, you can't give them a beta blocker because the beta blocker will stop it even more. So you cannot give them a beta blocker there. Tamam? Now, the drugs that we have not discussed are digoxin, phosphodiesterase 3 inhibitors, SGLT2 inhibitors, and sacubitril and valsartan. For digoxin, what did we say its mechanism of action? Do you guys get the concept of afterload and preload? Okay, so I shouldn't explain. Come. For digoxin, like you said, it's a sodium-potassium ATPase inhibitor. So it prevents sodium from exiting, sodium efflux, and prevents calcium from, or actually increases calcium inside the cardiac cell. And this causes increased contraction, increased cardiac contraction. So you're waking up the heart. This is how digoxin works. What are its adverse effects? Three main things that you should think about regarding digoxin. Three keywords that if asked, they usually get asked about. Anorexia, remember anorexia, could cause anorexia, could cause yellow vision, xanthopsia, and could cause arrhythmias. Hell. Three things with digoxin. Okay, this is done with digoxin. Digoxin simple, direct, and straightforward. Then we have phosphodiesterase 3 inhibitors. What do phosphodiesterase do? We already said. They break down cyclic AMP, and so they decrease the levels of cyclic AMP. If you give an inhibitor, it increases cyclic AMP. Why is that important? What does increased cyclic AMP do? Causes contraction. No, it increases. Okay, it could cause vasoconstriction in the blood vessels, but phosphodiesterase 3 acts more on the heart, such as milrinone and amrinone, and the increased cyclic AMP in the cardiac cells causes increased contractility. Tamam? The phosphodiesterase you're speaking about is phosphodiesterase 4. Similar concept. Then you have SGLT2 inhibitor, like cangliflozin. How does it work? What does SGLT2 stand for? Sodium glucose transport, essentially. So it's in your kidneys, the tubules. It helps you absorb sodium and glucose to absorb more fluids. With the sodium, if you inhibit this channel, you're excreting more sodium and glucose and water with it. It is an anti-diabetic drug, but it could be used for heart failure to, like you said, decrease mortality. Okay, are we good with those 3 new drugs? Okay, one final drug is sacubitril and valsartan, which is also our neprilysin inhibitor. And I'm sure you guys know what AMP and BMP are. Do you guys? Okay, so over here you can see the digoxin activity. It inhibits sodium potassium ATPase. Remember this picture very well. You could get asked about it in OSPE. They will hide this digoxin and they would be like, which drug acts on this? Or you should point out where is the mode or where does it act on? So remember, it acts on a sodium potassium ATPase. Yeah, it's a random OSPE question. Exactly. Out of nowhere. طيب. This is what AMP and BMP do and how they get released. Yeah, exactly. Muhammad. So this is for AMP and BMP. Imagine you have your heart, again, heart failure. What happens? Blood is coming into your heart and it's not pumped out. Getting in heart, not pumped out. So heart gets enlarged and distended and distended and distended. The more distension of the heart, this causes the release of AMP and BMP. They are protective mechanisms. What do they do? What they do is they go to the kidneys and they increase excretion because there's too much fluid in it understands that there's too much fluid in your heart right now. So they are naturally found peptides. They get released, they go to the kidneys and cause natural release. The other way they act is cause vasodilation. It's the exact same way we want to treat heart failure. Subhanallah. Like our body has a mechanism to prevent heart failure on its own. It decreases the heart, the volume overload in the heart through AMP and BMP. But where does neprilysin come in? Neprilysin comes in and it starts breakdown of AMP and BMP. And this is why we give a neprilysin inhibitor, because AMP and BMP are actually good in this situation. Tamam? So this is where neprilysin comes. And the drug we use is sacubitril valsartan. What is valsartan? Arab. Okay, one or a couple more things. Okay, so this slide is the drugs that prevent cardiac remodeling and they improve survival in heart failures patients. So as we said, ACE inhibitors, beta blockers, potassium sparing diuretics. And as you can see from the amazing stars over here, this is very high yield, by the way. If it's not high yield in your exam, it's going to be high yield in your steps. You must memorize ACE inhibitors, beta blockers, potassium sparing. Very easy. A, B, K. Right. One last thing, let's talk about acute decompensated heart failure. So I already mentioned it. In acute decompensated, yeah, that's exactly, that's my alphabet. For acute decompensated heart failure, your heart is not pumping. Khalas, it stopped pumping. So you need to relieve it as much as you can. So there are certain protocols you need to follow to treat that heart. But there is a mnemonic for it, LMNOP. LMNOP. L is for loop diuretics. Why are loop diuretics important? Because we already mentioned it causes extracellular fluid depletion. You lose a lot of volume. So it's very good. Loop diuretics are important. And you have to modify medication. So if the patient is on beta blockers, we said it is contraindicated to give them beta blockers as in acute decompensated heart failure. The heart is not pumping. And beta blockers causes the heart to stop pumping even more. But you should stop beta blockers. And you should start dobutamine. Dobutamine is a drug that causes what? Cardiac contraction. Did you guys take dobutamine? I didn't see it in any of the lectures, actually. But yeah. Maybe in your clinical lectures. Yeah. Okay, so let's go back to our mnemonic. LMN. N is for nitrates. You give them nitrates and causes venodilation. O is for oxygen. And P is you position them upright. Everything is over here. For acute decompensated heart failure, give them LMNOP. Perfect. Okay, I think we could take a break for like 5 minutes. And then we continue with the rest of, we reach almost half point right now. We just have antiarrhythmics left for cardio and then the rest of pulmonary.
1.
Okay, Bismillah. Okay, let's go on. Question 16. A new antiarrhythmic medication, drug A, is tested in a series of experiments that measure the flow of ions responsible for producing an action potential in cardiac muscle cells. Ion flow is measured before and after the drug is administered, and the results are shown in the chart below. Each colored line represents a different type of ion, okay? So over here on the top, you can see the normal myocardial action potential, and then the differences in ion before the drug was given and after. Okay, so we have a C. Any other answers? Okay, so the answer to this question is C, as you said, amiodarone. It's a class 3 antiarrhythmic that blocks your potassium channels, huh? Blocks potassium efflux. So over here, if you compare it to the myocardial action potential, you can see in this upstroke, you have this blue line that's rising. What's this blue line? That would be which ion? Sodium, صح? ممتاز. And then over here, you can see at the plateau phase, you have this ion starts rising. So it increases into, it goes into the cell. This is calcium. And then this ion starts exiting, which is potassium. صح? Yeah. And so over here, after you give the drug, you can see that the potassium, the amount of potassium exiting is even less, and it's prolonged. So this indicates a potassium channel blocker. And of those, which one is a potassium channel blocker? Amiodarone, class 3 antiarrhythmic. Okay, moving on. Okay, a 24-year-old man comes to the emergency department due to the sudden onset of palpitations. The patient says it feels like my heart is racing. He had an episode similar to this a year ago that resolved spontaneously. Blood pressure is 126/74, and pulse is 164. Rapid intravenous administration of a medication to this patient results in instantaneous resolution of the arrhythmia, but is accompanied by short-lived flushing, burning of the chest, and shortness of breath. Which of the following medications was used to treat this patient's condition? صح. Adenosine. So this patient sort of has a supraventricular tachycardia. And what's the first line medication for it? Especially given IV? Adenosine. ممتاز. We'll talk about, again, mechanism of action later on. You guys know how does it work? How does adenosine work? Potassium channel, potassium conductance. Okay. Question 18. By looking at the following figure, which class of antiarrhythmic drugs does this action? A, صح? So what can you see the changes happening over here? The normal depolarization, the upstroke, and then it 1A. Perfect, yeah. We'll talk about how they differ, 1A, 1B, and 1C. Okay. Question 19. A 49-year-old woman with type 2 diabetes presents with 2 hours of chest pain and sweating. ECG shows ST elevation in 1 AVL. Perfect. LAD. After LAD stenting, she develops recurrent ventricular arrhythmias. She's treated with an antiarrhythmic drug. Which drug was used? Like you said, lidocaine. Why is lidocaine used? Because it is for post-myocardial infarction arrhythmias and post-myocardial infarction as well. So it's not only ventricular arrhythmias, it's because it came after a myocardial infarction. Okay. Yeah, we'll talk about it in a bit, the indication for each of those antiarrhythmics. Right, so let's review antiarrhythmics in general. Let's start with understanding the difference between action potentials. Right? You have two types of action potentials in the heart, the pacemaker action potential and the myocardial action potential. So which one is the fast one? The fast action potential, the myocardial action potential. Like each of them has, okay, let's actually show you the graphs. Yeah. So each of them has a shape that you guys need to understand and what ions go in and out during which phase. So over here at the left, you have the myocardial action potential at a negative 85 millivolts. And then you have a rapid upstroke. This is why it's called a rapid action potential. Over here in phase 0, even though it's written, what type of ion goes in? Sodium ions. And then you have after phase 0, remember the phase is by its name as well. After phase 0, you have the repolarization phase, which is divided into two parts. The slow repolarization, which is phase 1. Here you have potassium exiting. And then phase 2, you have the plateau phase, where what happens in phase 2? Calcium starts going in. And then you have the rapid repolarization phase, which is phase 3, where potassium starts exiting really quick. And then you have finally phase 4, where it returns to baseline. This is easy. For the pacemaker action potential, why is it called the pacemaker action potential? Because it's not at a baseline. There is always an inclination. Over here, you have phase 4. What type of channels are active here? The funny current. The funny current sodium channels. Funny current sodium channels specifically, yeah. Even though it's written sodium and potassium, but you have to remember the sodium channels. We spoke already about a drug that acts on those funny current channels. What was it? Ibabradine. Perfect. Okay, after this slow rise, you have a rapid upstroke or a sudden upstroke. This is through alpine calcium channels. This is where what type of drugs work? Calcium channel blockers. DHP or non-DHP? Type 4 or calcium channel blockers, DHP or non-DHP? Non-DHP. And then after that, you have the rapid repolarization. So you guys have a good idea of the action potentials now. So we could go into the drugs. So of the drugs, we already discussed the digoxin. So we said it works on the sodium potassium ATPase. We spoke about the beta blockers and the calcium channel blockers. So coming back to our slide that we already spoke about, where do beta blockers work? Why? Because it slows the action potential over here. So phase 4, it acts on phase 4. And then the calcium channel blockers act on phase 0. So because calcium enters during this phase, if you block it, you'd have a less steep paradigm. Okay, so we spoke about digoxin, we spoke about ivabradine, we spoke about the metoprolol, the esmolol, and verapamil and diltiazem. So those are done. Now we have class 1A, class 1, class 3, and adenosine left. Okay, are you guys good with that? Or do you want me to go over the other drugs as well? Good. Right. So let's start with class 1 antiarrhythmics. You have 3 types, class 1A, class 1B, and class 1C. Which one is the strongest? Actually, before that, what is their mechanism of action? We block sodium channels. And so sodium channels in which phase over here? Phase 0, the rapid upstroke over here. And so, okay, now which one is the strongest? That binds the strongest sodium channels? Class C. Then, which comes after it? A and then B. So 1C, 1A, 1B. Right. So think about it really quickly. What would happen if you block the sodium channels over here? the line, instead of a rapid upstroke, it would be tilted a little. It would be something like this. صح? And depending on the strength of each of those classes, so if it's 1C, would it go down or up, right or left? Because it's the strongest binding. Down, صح? And 1A less and 1B would be even least. صح? Okay, so this is done with. One thing you need to remember about class 1A is that it not only stops the sodium channels, it has what else? Some potassium blocking activity. So it also blocks the potassium channels as well. That would act on phase, the repolarization phase, or mainly phase 3. So phase 3. Okay, but now imagine phase 3 would be more extended to that way with potassium, with class 1A drugs. Okay, perfect. Now, once we've set all those rules, we have, okay, so let me show you this picture. Now, what drug is this? Which class? 1A, ممتاز. Why? Because you have a steeper, less steep slope for the rapid depolarization, and you can see the repolarization is affected as well. طيب. Which one is this? B. So this is class 1B, okay? Finally, okay, class 1C. Can you guys see the difference? So class 1A is sort of in the middle. Class 1B is very close to the original. Class 1C is very far away because it's the most potent. Perfect. Right. Now let's talk about action potentials and QT intervals. So for class 1A, does it affect their action potential? Is it prolonged? Is it decreased? Just thinking about it. It is prolonged. And the QT? Prolonged as well. صح? طيب, how about class 1B? Now that you have the picture in mind, you could tell what happens with the action potential and QT. Prolonged برضو? What do you think? So it usually the action potential lasts till this point. Now it stops a little earlier. So you have decreased action potential. And with the decreased action potential, you'd have a decreased QT interval. So both of them will actually be decreased. Right. For the last one, class 1C, you can, no change. So this is exactly it. So action potential and QT is affected in both, is increased in 1A, it's decreased in 1B, and no change in 1C. Right. What is changed in 1C? There is something that does change. You have a widened QRS interval, okay? The QRS gets bigger. What is the QRS? Ventricular depolarization, or the ventricles start depolarizing and contracting. So now, if you look at 1C, you can see that the ventricles, instead of contracting here, they take longer to contract. But they do have a widened QRS. But their action potential and QT remain unchanged. But this is one of the hallmarks actually in the questions you could find. They tell you مثلا إنه the patient, even after running very quickly, their QRS intervals remains the same, or is still 400 milliseconds. تمام? It is useful in ventricular arrhythmias. We're going to talk about their indications now. صراحة, for indications, I will not lie to you, it is sort of, it's all over the place. However, the main one that you need to remember is for class 1B, and you already mentioned it. Why do you use class 1B drugs? In which scenario? Post-MI. Arrhythmias post-MI. So acute ventricular arrhythmias post-MI. But for class 1A and class 1C, you could use them for atrial fibrillation, atrial flutter, and for ventricular arrhythmias in general. No specific No more specifics. طيب, let's take a look at adverse effects. Okay? So for adverse effects of each of the classes, again, it's very important. The most important one to remember is class 1A adverse effects. Okay? What are the adverse effects in class 1A? Mhm. It's pro-arrhythmias. Why? Because we already mentioned something. It could cause torsade de points because it has a QT prolongation. It's the only one that causes QT prolongation. But they also said kynoconism. What is kynoconism? Tinnitus and headache. Okay? You have SLE-like syndrome, and then it could cause heart failure. Again, because of the prolonged action potential and QT, causes slows down the heart. Like this is for 1A. You need to memorize them, remember them. 1A could get asked. For class 1B, very vague symptoms. You'd have either CNS stimulation or depression, and cardiovascular depression. Very vague. Tremors, which is CNS stimulation, exactly. But and the last one, the class 1C, it is pro-arrhythmic. But it is pro-arrhythmic in a single scenario. Post MIs, exactly. So remember, class 1C is for pro-arrhythmics, post MIs. Which examples? Yes. So remember, for class 1A drugs, you need to remember at least one of them, either quinidine or procainamide. For class 1B, you have lidocaine. Remember lidocaine. For class 1C, you have flecainide. But remember one of each. طيب. Now we're done with class 1 drugs. Are you guys good with them? Once you understood them, they're simple, they're good to go. Okay, class 3 antiarrhythmics. You have, okay, so you have their mechanism of action. Where do they work? Amiodarone, yes. It works at the repolarization, mainly phase 3, exactly. Mainly phase 3. طيب, mechanism of action, potassium channel blocker. So prolongs action potential. So yeah, try to remember it. Anything that acts on the potassium channels causes prolonged action potential duration. So class 1A drugs, we already mentioned how they have a certain activity on the potassium channels, but they prolong the action potential duration. Every other drug does not act on the potassium channel. But the main thing that affects action potential duration if they have an action on potassium channels. But now, if you look at this drug, it causes a prolonged action potential. So if I ask you action potential and QT over here, they'd both be increased. Makes sense? Like adverse effects, very important to remember for amiodarone. Very important. You have like 5 you could mention. Not cataracts, but it does do something to the eye. It causes corneal deposits. Okay. It causes blue-gray discoloration of the skin. Now, 3 very important things you guys are forgetting. Before starting a patient on amiodarone, you need to check 3 things. Thyroid, correct? 2 more? No, not renal. Thyroid, pulmonary, and liver. PFTs, LFTs, and thyroid function tests. Because it could cause pulmonary fibrosis, it could cause hepatotoxicity, and hypo or hyperthyroidism. Remember, those are the 3 things that you need to test before starting a patient on amiodarone. Now, what do you have on the left over here? Opacities, you could say corneal deposits, and the one on the right, blue-gray discoloration. All right, and final medication we have is adenosine. Already spoke about adenosine. How does it work? Mechanism of action. potassium out of the cell. So it causes hyperpolarization. It decreases your AV node. And so it is the drug of choice in what? Supraventricular tachycardias. Type. Adverse effects. Very important to remember. One characteristic finding in adenosine. If it's mentioned, خلاص, it's 100% adenosine. Flushing, yes, it could cause flushing, could cause chest pain, sense of impending doom or feeling of doom. Remember, sense of impending doom. All right, so this is for adenosine, and this is the end for antiarrhythmic drugs. خلاص, inshallah. Good with everyone? All right, moving on to pulmonary. Pulmonary is way simpler than cardio. Inshallah, we won't take as long. Cardio just had a lot of physiology that we need to go back to. Pulmonary doesn't have much, very direct. Let's start with a 10-year-old girl. She's brought to the emergency department because of severe shortness of breath and dry cough for 30 minutes. The symptoms started while she participated in a soccer tournament at her school. Her father was diagnosed with asthma as a child. Her pulse is 130 per minute and respirations are 35 per minute. Treatment with inhaled albuterol is initiated. A physician administers a second drug to increase the action of albuterol on bronchiosmooth muscle cell receptors. Which of the following drugs is most likely to have had this effect? Okay. Any other answers? Could be B. B. It is prednisolone. What is prednisolone? It's a glucocorticoid. So I want you guys to remember one thing when it comes to treatment of asthma and COPD in general. So you always start with the bronchodilator, and to make it better, you add a glucocorticoid to it. So those are the two things, the main treatment, like first line treatment, bronchodilator and the glucocorticoid. Like the difference between asthma and COPD is the bronchodilator. You'll always have the glucocorticoid, but for the bronchodilator in asthma, you prefer what? You have two types of bronchodilators. You have the beta agonists and the muscarinic agonists. Huh? Asthma, you prefer the beta, exactly. So you start them usually on short-acting beta agonists, such as salbutamol or albuterol. Now, the COPD drugs, you prefer the antimuscarinics. So you give them ipratropium or, yeah, I only have ipratropium in one. Exactly. Thus, the glucocorticoids remain the same. Magnesium sulfate, irrelevant. Prednisolone, we already said. Theophylline is not first-line treatment. The methylxanthines. Cromolyn sodium is used for what? What's the use of cromolyn sodium? Prophylaxis. Mast cell rises, it is a prophylaxis. You don't give it for treatment, for current treatment. You give it as a prophylaxis to prevent it from happening in the future. Then you have Montelli class, which is a leukotriene antagonists, and then apratropine antimuscarinic. Tamam? Is this good with everyone? Right. Over here, you have an otherwise healthy 13-year-old boy is brought to the physician because of asthma attacks that have been increasing in frequency and severity over the past 4 weeks. He was first diagnosed with asthma 6 months ago. Current medications include high-dose inhaled fluticasone and salmeterol daily with additional albuterol as needed. He has required several courses of oral corticosteroids. A medication is added to his therapy regimen that results in, I hid this for now, I'll see if you guys can find it without it. Which of the following drugs was most likely added to this patient's medication? So he was started on the standardized therapy, which is glucocorticoid and fluticasone and salmeterol, normal standard. What will you add if it gets worse? B, okay. So if I remove this medication is added to his therapy regimen that results in downregulation of the high affinity IgE receptors on mast cells and basophils. حرام عليك. Why did you change your answer? Yes, B, omalizumab. It is an antibody against IgE receptors. تمام. فagain, continuing with the flow, you start with short-acting beta agonist. You add glucocorticoid. If it gets worse, you add omalizumab. Simple, صح? Moving on. A patient with asthma continues to have frequent exacerbations despite being on standard therapy. Which of the following is the next best treatment option? This is how it will get asked in the exam, by the way. And the previous question is a long question, probably will not get asked. This is omalizumab, and this is how it will get asked in the exam, inshallah. Right. Let's see this patient, a 16-year-old boy. Final question before we get into the lecture. A 16-year-old boy with a history of asthma presents for follow-up. He's adhering to his prescribed low-dose inhaled corticosteroid and uses his albuterol inhaler as directed. Despite good adherence, he continues to experience chest tightness, cough, and wheezing almost every time he plays soccer, which resolve within 20 minutes of rest. He has no nighttime symptoms, and his baseline spirometry is normal. Physical examination today is unremarkable. D, long-acting muscarinic antagonist. Did we say we give long-acting for muscarinic antagonists for asthma? C, what is E? Oral prednisolone. He's already taking an inhaled corticosteroid. We're going to start him in an oral. B, what are you thinking of when you say B? What drug? Montelukast, okay? Montelukast. So what is montelukast? It's a leukotriene antagonist. What it does is it prevents the release of leukotrienes and stuff, which causes bronchoconstriction and increased airway reactivity by releasing other cytokines. You're blocking that with montelukast. What is the key word in this case that you would choose montelukast for? Is this patient has wheezing every time he plays soccer. Now again, the patient is started with standardized therapy, corticosteroid, and a short-acting beta agonist. Then it gets worse with working or exercising or stuff. You start a leukotriene antagonist, especially montelukast. Tamam? So I think the concept of asthma is now simple for you guys. Every single other drug, yani more or less, you won't get asked about unless it's just mechanism of action or something. Right. So now for drugs for asthma and COPD, the whole idea of asthma and COPD is that you have bronchoconstriction, airway inflammation, and hyperreactive airway. Now, the difference between asthma and COPD is that asthma is reversible, while COPD is not reversible. Right? Now, for the drugs, you have this amazing diagram over here that speaks about all the drugs. Again, we mentioned the standardized therapy is a bronchodilator along with a corticosteroid. And this is the standardized therapy. Depending on whether he has asthma or COPD, you could identify which bronchodilator you need. For asthma, we said it is beta agonists, such as salbutamol, terbutaline. Can you guys tell me the adverse effects of those drugs? What can they cause? They are beta agonists, huh? Where else do you have beta receptors? Tachycardia, exactly. It could act on the heart and cause tachycardia. Mumtaz. Then you have the other drugs, which is like ipratropium, okay, methylxanthines, mechanism of action. How do they work? ADP. You guys remember ADP receptor? Not ADP, adenosine A2 receptors. And then you also have a phosphodiesterase. Yeah. So it works by phosphodiesterase inhibitors, phosphodiesterase 4, which increases cyclic AMP, and this causes a bronchodilation. Tamam. This is one action. And the other action is that it inhibits the A2 receptors. Hell, this is for methylxanthines. very low yield drug, but remember their mechanism of action in case they get to ask you. Adverse effects, again, very narrow therapeutic index, because it has a very narrow therapeutic index, and it could cause CNS issues such as seizures and dizziness and stuff. But this is for methylxanthines. Sympathomimetic is done, methylxanthine is done. Then you have anticholinergic drugs. Apratropium. Adverse effects. Actually, let's not get into the adverse effects. I don't think you guys took it. So we're done with bronchodilators. Let's go into Allahumma salli Muhammad, corticosteroids. You guys are good with corticosteroids. Adverse effects of corticosteroids. You have a billion adverse effects, but you need to differentiate between systemic corticosteroid and inhalational corticosteroids. For systemic corticosteroids, you could have a lot of stuff such as osteoporosis. You could have growth stunts in kids because of the osteoporosis. Like inhalation, you could have also adrenal suppression. For inhalational corticosteroids, there is one thing you need to remember. Because what on the tongue? Candidiasis could cause oral thrush. Okay. Then you have the leukotriene antagonist drugs. You have montelukast, and the other one is ziltion, not this one. But essentially, they work the same by inhibiting lipoxygenase drugs or leukotrienes from getting released. Then we also spoke about mast cell stabilizers. What do you need to remember about it? They are prophylactic drugs. And how do they work? Mechanism of action. This one is always slept on. Cromolyn sodium works by inhibiting calcium entering into the mast cells. And so when calcium does not enter, the histamine vesicles do not release their histamine, do not bind to the membrane and release histamine. This is the mechanism of action of cromolyn sodium. And then we spoke about omalizumab, how it works as an anti-IgE antibody. Hello? Over here, next slide. Yeah, over here you can see the leukotriene pathway. And so this is how montelukast and ziltion work. They block this. Ziltion blocks 5-lipoxygenase. Montelukast, I think, blocks D4, to be specific, for leukotrienes. And so essentially, leukotrienes cause bronchoconstriction. And so if you block bronchoconstriction, you'll have bronchodilation. All right. We're done with asthma and COPD. Any questions? Are you guys getting tired? Right. For question 24, a 35-year-old man presents with a stuffy nose due to seasonal allergies. He starts using an over-the-counter nasal decongestant spray containing phenylephrine. Which of the following is the most important side effect he should be warned about? Rebound congestion if used for more. Rebound congestion if used for more than 3 to 5 days. Exactly. Question 35, a 12-year-old boy presents with a persistent nighttime cough during an upper respiratory tract infection. He has a history of asthma with recurrent episodes of wheezing and shortness of breath. Which of the following antitussives should be avoided in this patient? D. Is acetaminophen an antitussive? C. Why C? What is guaifenesin? It's a mucolytic, huh? It breaks down your mucus. So why would you give someone who has mucus a mucolytic, or not give him a mucolytic? You'd need to give him guaifenesin. So it's not C. The question is asking which of the following should be avoided in this patient. Okay, what is B? It's an antitussive. Okay. But what about A? Why do you guys hate A so much? Okay, so This is a direct question from your slides. The answer to this is A, codeine. You should not give codeine. Yeah, it is codeine. So you should not give codeine to patients who have asthma. That's one. And they have, yeah, a respiratory tract infection. So over here, he'd have fluids or more mucus coming from his respiratory tract infection. So both of those are indications or contraindications to not use codeine. Okay, remember it. Good. Can we move on? Right. Drugs for upper respiratory tract infection. It is one of Dr. Dana's lectures. Very direct. Nothing much you need to go into except studying the green. However, here is essentially what you need to do. For a patient with an upper respiratory tract infection, you need to focus on hydration. Antipyretics. What are antipyretics? What do they do? They're anti-fever drugs, decrease fever. So they have acetaminophen and NSAID. What is the mechanism of action of increased temperature or fever? How does fever happen? Yeah, so you'd have a lot of cytokines released from whatever exogenous or endogenous pyrogene. And this causes the set point in your hypothalamus from being at 37 to increase to up to 38 or more. This is how you get fever. Acetaminophen and NSAIDs, they are COX inhibitors, and they prevent the release of all of those cytokines, and they reduce back your set point. Like drugs for cough. Now, here is a lot of talk about drugs for cough. You have antitussives, and we already spoke about dextromorphan and codeine. Okay? They work by inhibiting the mu receptors or opioid receptors. This is for those two drugs. Then you have anti or mucolytic drugs, which you already spoke about, such as guanifenicin. And those essentially break down your mucus. One thing about the codeine that you already said is that it should not be given for patients who have mucus or productive cough, or patients who have an asthma, because it could make it worse. For nasal decongestants, what drugs do we have? We also had a question about it. Phenylephrine. Okay? Phenylephrine or phenoxybenzamine. What does phenylephrine or phenoxybenzamine do? They stimulate your alpha 1. They are alpha 1 agonists. So what does alpha 1 do? What did we say they do? Vasoconstriction. So they decrease the flow of blood to your nose. And so essentially, by reducing this, you have less mucus coming out from the blood. They are nasal decongestants. And what is their serious adverse effect? Rebound congestion. Right. And then you have antihistamines to reduce your give me a drug that is an antihistamine. Cetirizine. Right. And then a diphenhydramine as well. What do you have to be wary of, afraid of, take care of? Sedation. Yeah, especially with first-gen antihistamines. Then you have cromolyn sodium, which you already spoke about in the asthma and COPD drugs, and they cause what? Their mechanism of action? Mast cell stabilizers by preventing calcium entry. Hey. Over here, you can see the how fever happens. So you have a lot of pyrogens, it causes the release of a lot of cytokines and interleukins, and eventually increases the set point. We're done with this lecture. Any questions? Again, with Dr. Dana's lecture, all you need to know is the green. Now, question 26. A 55-year-old man from Azerbaijan presents with a 6-week history of recurrent fever, productive cough with hemoptysis, fatigue, and 8-pound weight loss. He has poorly controlled type 2 diabetes on insulin. Chest X-ray shows a cavitary lesion in the right upper lobe with a surrounding consolidation. He is started on combination therapy. Sputum culture identifies a pathogen resistant to drug that interferes with pyridoxine metabolism. Which of the following explains this mechanism of action of resistance? Yeah, so which of the following best explains the mechanism of resistance to this drug? We have an F. Any other answers? Okay, so the answer is F. What drug are we thinking about? Isoniazid. Type. What is A? Ethambutol. Altered structure of 30S ribosome component. This is probably like doxycycline or something. Changed amino acid composition of DNA gyrase. This is more about fluoroquinolones. Impaired conversion to pyrazinic acid. I'm not sure which drug this is. Maybe pyrazinamide. Mutations in gene encoding RNA polymerase. What drug works in RNA polymerase? Rifampicin. Huh? So generally, if you could eliminate the answers and find out that the only one remaining is catalase peroxidase, or what's it also called? CAT-G. So if you have resistance to CAT-G or no catalase peroxidase, the isoniazid would not work. What is the mechanism of action of isoniazid? Inhibits formation of mycolic acids. Like, we'll talk about their adverse effects as well. This lecture is very important, by the way, like the anti-TB drugs. There's a lot of high yield stuff that you guys need to remember. But I'll tell you to focus on the main drugs, like RIPE, and their adverse effects. That's all you need from them. But be good with them, be really good. Oh, actually, the 30S that just came to me, it could be streptomycin as well. Okay, this question. 27, a 58-year-old man with type 2 diabetes comes for a routine checkup during the exam. The physician notices visual problems, including red-green color vision defects, but no signs of diabetic retinopathy. Review of his medication reveals that he is being treated for tuberculosis. Which of the following anti-tuberculosis drugs is most likely responsible for his visual symptoms? And the answer is 3, 2, 1. Ethambutol. Exactly. So ethambutol causes red-green color vision blindness. All right. Which of the following best describes a key pharmacological effect of rifampicin? We already sort of mentioned it on one of the drugs. Induces cytochrome P450, inhibits mitochondrial enzymes. So it induces cytochrome P450 enzyme. And what drug did we say it affects? If you guys can remember, warfarin. So warfarin has a lot of like pharmacokinetic. Yeah, so induces cytochrome P415. So yeah, so warfarin could get affected by this drug because it is metabolized by cytochrome P450. And so this drug decreases warfarin activity. Moving on. Let's talk about the anti-TB drugs. So why is anti-TB drugs or tuberculosis hard to treat? Because of three main things. It is resistant to a lot of the medications you have. It is dormant, and it forms like a granuloma and prevents a lot of the drugs from going in. So it is impermeable. Like the main drugs you need to think about are RIPE plus streptomycin that has been added. Like, this diagram over here is from your lectures, and it explains all you need to know about each drug. So let's test your knowledge, actually. Which drug is used for, we already sort of touched upon the mechanism of action, but can you guys give me the adverse effects of, for example, let's say isoniazid? Hepatitis, and one very important one. Peripheral neuropathy. Do not forget peripheral neuropathy. And this happens because B6, deficiency in B6. Right. Let's talk about ethambutol. You already said red-green color vision. Pyrazinamide. Pyrazinamide is hepatotoxic. Okay. and could cause hyperuricemia or gout. There's a lot of drugs we spoke about today that could cause hyperuricemia and gout. Like rifampicin. Rifampicin, there's one very important adverse effect. It could cause, pink red discoloration of bodily fluids. Okay. Our final one is streptomycin. Streptomycin is a protein synthesis inhibitor, and we said it works on the 30S. Like adverse effect, one very important one, ototoxicity. Remember, ototoxicity. Now, also the mechanisms of resistance, unfortunately, you're going to have to memorize for those 4 drugs, or at least focus on rifampicin and isoniazid. For rifampicin or isoniazid, we actually already mentioned catalase activity, CAT gene, or INH gene. And then for rifampicin, you have the RNA polymerase itself has a conformation change. Right? But this slide over here, you could see the adverse effects linked to man. So for example, E for the eyes, because it causes ethambutol causes red-green color blindness. S for streptomycin on the ears, ototoxicity. RIP on the liver, rifampicin, isoniazid, pyrazinamide, the red-pink fluids for rifampicin. Isoniazid causes peripheral neuropathy for the fingers and the feet, and then P on the for gout, hyperuricemia. Tamam? Okay, almost done, خلاص. I think we have 3 more lectures actually. 3 more lectures to go. We're almost there. Bismillah. Anti-cancer drug, one of the lectures that everyone skips over. However, there is basically, if you answer this question, you'll get your question tomorrow correct, inshallah. Which of the following drugs works primarily by inhibiting angiogenesis? D, bifacizumab. Exactly. Just memorize this, inshallah, you'll get it exactly on the same. Right. Yes, remember this is an adverse effect as well for bifacizumab. If they don't ask you about which drug causes angiogenesis, remember its adverse effect, which is hypertension. Question 30. A patient with metastatic non-small cell lung cancer is started on a drug that blocks PD-1, enhancing the immune system's ability to attack tumor cells. Which drug is this? So it blocks PD-1. B, ممتاز, nivolumab. Again, bifacizumab anti-angiogenesis. Those 2. The last one is irrelevant. This one is an EGFR inhibitor we're going to talk about now. But for anti-cancer drugs, summary of lung cancers, you could divide them into small lung cancer and non-small cell lung cancer. For non-small cell is the one that we're going to be targeting more for our drugs. Like for anti-cancer drug therapy, I want you guys to divide it into targeted therapy and immunotherapy. Targeted therapy, the first 3 have the exact same mechanism, just different namings, you know? So this is their mechanism of action. You have EGFR inhibitor, you have a receptor, and EGFR binds to it, and this causes proliferation. So the EGFR inhibitor inhibits this effect and causes the tumor cells to not proliferate. Adverse effects, rash and diarrhea. Not important. طبعا all anti-cancer drugs cause alopecia and hair loss and they affect anemia and stuff. But ALK inhibitors, exact same thing. You have a receptor and ALK binds to it. Causes prevent the cell growth and proliferation. Adverse effect, hepatotoxicity, ILD, plus rash and diarrhea. So till now, they all have rash and diarrhea, and you just add hepatotoxicity and ILD. Last one is again tropomyosin tyrosine kinase inhibitor, intracitnine. Okay, same thing. Receptor binds to it, causes proliferation. So inhibit this binding, boom, no proliferation. Increase creatinine, anemia, and hyperuricemia. Now, I don't think they're going to ask you about those drugs. They're very, because those drugs are very specific. You only give them when you test the patient and they turn out positive for that certain mutation. So if the patient has a non-small cell lung cancer and they are positive for an EGFR mutation, okay, then you could give them EGFR. But if they're not positive, you probably won't use them. What is the drug that you'd use in every one of those therapies is bifacizumab, because it's an anti-angiogenesis therapy. It attacks all types of lung cancer. Tamam. If something really is going to get asked about in this lecture, it's probably bifacizumab. If I remember it for your exam, inshallah. And again, what did we say the main adverse effect of it? Good code. Hypertension, not hypo, hyper, because بيرفع الضغط. Increased risk of bleeding and impaired motility. Okay. Right. Now, for immunotherapy, this is a concept of how normal body cells work, by the way. So you have this normal body cell. It has a PDL1, yeah, exactly, Dr. Gunn, right now. So you have a normal cell, you have it expresses a PDL1 ligand over here, and then you have a T cell that expresses PD1. What happens is the T cell goes around and it sees the normal cell. It sees that it has a PD1, so it's like, no, this is my cell, this is self, I don't attack it. This is the exact same mechanism cancer cells use to evade the immune system. So the cancer cells, they're not normal cells, they're proliferating, but they express PD1, PDL1. And so when the T cell comes, it sees PDL1 and it does not attack. So the cancer cell remains alive. Tamam? So what happened is they introduced drugs that break down either PD1 or PDL1. And those drugs are nivolumab or atezolizumab. But now you don't have either one of those, and the body cells, the T cells, start attacking every other cell. So if I ask you now, what is the adverse effect that comes to mind right away when this mechanism happens? Autoimmunity. You need to remember autoimmunity. Why? Because now there is no protective mechanism for your normal cells. Your T cells are going and they are going to attack every other cell in your body. So this is why autoimmunity is any general autoimmune reaction will happen after starting these medications. Tamam? Okay, done with cancer drugs. If you're gonna get asked, inshallah, only bevacizumab. Worst comes to worst, nivolumab for PD1. Okay. Moving on. Question 31. خلاص, almost there. A 45-year-old patient with suspected pulmonary arterial hypertension undergoes a vasoreactivity test during right heart catheterization. The test shows a drop of 10 millimeters in mercury in mean pulmonary artery pressure. Which of the following is the most appropriate next step in management? Endothelin receptor, phosphodiesterase, calcium channel blockers, prostacyclin. Yalla, or B. A or C or D or B. So the answer to this is C. Again, the key word to this scenario is this patient has a vasoreactivity test and it's positive. It shows a drop of 10 millimeters in mercury of blood pressure. And ideally, it should have mentioned that it is below 40. The pulmonary artery pressure is below 40 millimeters mercury. But in this scenario, when they have a vasoreactivity test positive, for those pulmonary hypertension patients, you only have one drug to start. Calcium channel blockers. There is no discussion. We'll talk about it more at the end, inshallah. But now, this is a 37-year-old woman. She has had progressive exertional dyspnea for 1 year. Now unable to walk. Half a block without resting. She also experiences exertional lightheadedness. Exam shows a holosystolic murmur at the lower sternal border that increases with inspiration. Workup includes lung disease and venous thromboembolism. Cardiac catheter, mean pulmonary artery pressure is 43, pulmonary capillary wedge pressure is 9. Pharmacotherapy blocking the effects of which substance would most benefit this patient? So again, this patient has pulmonary hypertension, huh? Which drug should you start in this scenario? Out of all the answers, endothelin is the only answer. But norepinephrine, you would not give them. It would make it worse, actually. Angiotensin, same. Aldosterone, same. Serotonin, even given. But C is exact. Endothelin or bosentan. Fine. So I know you guys took the pulmonary hypertension lecture a little too late, and I'm not sure if you guys have time to know it. However, over here, I made like a diagram of how you should approach the general situation of a patient with pulmonary hypertension. So if you have a patient with pulmonary hypertension, first of all, you do an acute vasoreactivity test. What is an acute vasoreactivity test? You start the patient on a potent vasodilator, such as nitric oxide. You give them nitric oxide, and you measure their mean arterial pulmonary pressure. طبعا for pulmonary hypertension patients, the definition is when they are hypertensive, يعني, it is more than 20. The acute vasoreactivity test, once if it's positive, means that they lost 10 millimeter mercury of this pressure after you administered the vasodilator. So if this happens, then they are acute vasoreactivity test positive. And the only drug that you should start in this scenario is calcium channel blocker. You start it for the first 1 to 3 months. And then you follow up with them after. If after 1 to 3 months, they are not reactive or not responsive, or they're not responding to the calcium channel blocker, then you have to go to step 2. What is step 2? WHO class. So you classify them into class 1, 2, 3, or 4. And I'm sure you guys know what are the classes of pulmonary hypertension. But so for class 1 patients, you usually observe. You only treat their contributing factors. This is for class 1 drugs. For class 2 patients, you have 2 main drugs to give. You give them an endothelin receptor antagonists, such as bosentan and ambrisentan, and tadalafil. But what do the endothelin receptor antagonists do? Because vasodilation. And the tadalafil, exact same thing. How does it work? By which mechanism exactly? Tadalafil, it's a phosphodiesterase inhibitor. Phosphodiesterase 5. Phosphodiesterase 5 inhibitor. So it increases or prevents the breakdown of cyclic GMP. So when you have more cyclic GMP, you'd have more vasodilation. But this is for bosentan and tadalafil for class 2. For class 3, you have the exact same regimen. However, if you notice that the patient has rapid progression or is becoming worse rapidly, you start them on epoprostenol IV. Okay? What is epoprostenol? Epoprostenol is a prostacyclin analog. Okay? So exactly very similar to endothelin receptor antagonist. It goes and binds to its prostacyclin receptor. And once it does that, what happens? Vasodilation. Okay? Now it's given IV. Remember, it's given IV. Right. Last thing is class 4. Class 4 is sort of severe, and you have to start them directly on IV epoprostenol or any other alternative prostacyclin therapies. So you have epoprostenol, triprostenil, iloprost, selexipag, any of those, you start them. And if you find no improvement in any of those patients, you'll have to do what? Lung transplant. No solution. You have to do lung transplant. Tamam. Right, now let's take a look at the adverse effects. So for adverse effects, let's go from right to left. So for epoprostenol or the prostacyclin analogs, there is one adverse effect you guys have to remember, which is jaw pain. Remember jaw pain. It's very characteristic of this drug. Right, then you have bosentan and ambrisentan. There is also a single adverse effect you have to remember, which is hepatotoxicity. Jaw pain for epoprostenol and hepatotoxicity for bosentan. For the tadalafil and other phosphodiesterase inhibitors, because it causes vasodilation, you expect what? Hypotension and headache and flushing and all of those hypotension or vasodilating actions. Like, then you have 2 last, we actually spoke about calcium channel blockers. Plus, we're done with calcium channel blockers. We spoke about them a billion times. We're good. The last drug that we did not mention is an SGC stimulator, which is riociguat. It does the exact same action as phosphodiesterase 5 inhibitor. So it increases cyclic GMP. So you have inside the cell, you have a guanylate cyclase. And once you stimulate it, it increases the level of cyclic GMP. And once you have cyclic GMP, you have vasodilation as well. But again, have similar adverse effect, hypotension, and like the flushing and the headache and stuff. Tamam. Are you guys good with these? how, what do you mean by nitric oxide independent? Nitric oxide is not one of the drugs you'd give for, yeah, exactly. You just started, it starts on its own, basically. Exactly. Right, over here you can see the table, and it has all the drugs, again from your lecture, it has all the drugs. What you need to focus on is doping. It's found in actual exam questions. Focus on doping here, hepatotoxicity for endothelin receptors. And yeah, just follow this protocol and inshallah all good. Good for this section. Could go to our final lecture, inshallah. Like, final lecture, I put it at the end for a reason, and I'm going to let you guys know now, inshallah. Like, a 32-year-old woman presents to the clinic with a 3-day history of fever, productive cough, and pleuritic chest pain. She has no significant past medical history. On examination, her temperature is 38.3 degrees Celsius. Respiratory rate is 20 per minute. Blood pressure is 118/72 millimeters mercury, and oxygen saturation is 97%. Auscultation reveals crackles at the right lower lung feed. Chest X-ray shows a right lower consolidation. She reports a severe allergy to penicillins, with rash and facial swelling in the past. Which of the following is the most appropriate empiric antibiotic for this patient? Perfect. Azithromycin, which is macrolides. What are the other two? You have azithromycin and two more. Clarithromycin and erythromycin. صح? Clarithromycin and erythromycin. Again, the key word in this question is severe allergy to penicillin. So if you have severe allergy to penicillin, you have to start them on macrolides. And you cannot start them in penicillins. Amoxicillin is the penicillin, ceftriaxone is a beta-lactam. You cannot start them in a beta-lactam. And doxycycline is not indicated in this case. Right. Another patient is started on intravenous antibiotic for his condition, but develops severe pruritus and a rash immediately upon infusion. The antibiotic used in this patient demonstrates the following dynamics when tested in several healthy volunteers. So if you can see over here, once you give the drug, there is elevated levels of histamine. Keeps them going up. This is vancomycin. What is it called? The reaction? Vancomycin infusion reaction or Redman syndrome. Okay, because there's a lot of histamine release into the body. Exactly. So the answer is E. Now, one thing I was doing while preparing for this PAL is looking at your pneumonia lectures, and I found out that you guys did not take or study CURB 65 as part of your pharma. However, I think it is very important for you guys to be good with, and this is why I'll start explanation of the lecture by this CURB 65 score. I'm sure you guys, okay, so you did in clinical. So the CURB 65 is C for confusion, U is for blood urea nitrogen above 20, R is for respiratory rate above 30, B is for blood pressure less than 90/60, age is for more than 65. Each one of those is a single point. And depending on their case, you could identify whether the patient is an outpatient, inpatient, or an ICU. Okay. But next, we could go on to, this lecture was basically a review of POD, but I'm going to teach you guys how it is actually treated in real life, inshallah. Because there are certain protocols. So first, you do the CURB 65 and you identify the patient. Then you go into the empirical therapy. So what are the common causes of community-acquired pneumonia? What is the most common cause of community-acquired pneumonia? Strep pneumonia. Strep pneumonia. But you need to give drugs based on that. What drug do you start for patients who are suspected with strep pneumonia? Some beta-lactam, some penicillin, such as amoxicillin. Hell, there is amoxicillin, you could give them augmentin, depending on the case. But if penicillins do not work, you start them on, or actually, let's go back, review. Penicillin works by doing what? Mechanism of action? The cross-linking, breaks down the cross-linking of the cell. Yes, BPP. But if Okay, and then penicillins, you need to know about their adverse effects. One of them is the allergies and stuff, or the hypersensitivity reactions that could happen from penicillins. Then you go on to the next in line. What comes after penicillins? Your macrolides. And what is the mechanism of action of macrolides? 50S ribosome. So they work on the prevent protein synthesis by working on 50S ribosome. Right. And then you have the last one, which was not mentioned in your slide, but it could be started, which is doxycycline. Hell. Right. So this is generally a protocol of how you could approach those patients. But you first categorize them on which they are outpatient, inpatient, or ICU. And based on that, you could give them the empirical therapy of choice. So for a general outpatient, you start them on amoxicillin for the strep pneumo. If they have some sort of hypersensitivity to it, you give them macrolides. For an outpatient patient with comorbidities, you give them combination therapy with either a beta-lactam, such as amoxicillin, you could give them augmentin, you could give them any of those beta-lactams that target strep pneumo, plus a macrolide or doxycycline. Or if this is not available, you can start them directly on a monotherapy with fluoroquinolone. But fluoroquinolone's examples, such as levofloxacin, you have what else? Gemifloxacin, you have moxifloxacin, all of those are examples of respiratory fluoroquinolones. But for inpatients, exactly same thing. So a patient who scored 2, you give them the exact same therapy, by the way. For an ICU patient, you have the exact same therapy, plus a combination therapy with fluoroquinolone and a beta-lactam. So again, you're targeting which bacteria caused the infection, and based on that, you could build on your antibiotic therapy. But for points to remember regarding this, let's say you have a patient, we already mentioned penicillin allergy, you start macrolide. 1 is done. Number 2, you're suspecting MRSA. What are the 2 drugs you could give if you're suspecting MRSA? You could either start them on vancomycin or linezolid, oral linezolid. Vancomycin is given IV. Linezolid is given oral. What makes vancomycin different from other beta-lactams? It works on a step before the cross-link, so the last one. But then you have piperacillin and tazobactam. It is given for Pseudomonas. So if you have a patient that started on Pseudomonas, you could give them piperacillin tazobactam, so anti-pseudomonal, or CVP. Finally, you have extended spectrum beta-lactamases. So those bacteria have a lot of beta-lactamases, and they break down your penicillins. But what is your drug of choice in this scenario? When all fails, you give them carbapenems. Exactly. You give them carbapenems. Okay. So again, this is stuff you guys did not take into details. However, I believe it's very important for you guys to know. Maybe not for the exam, but for later on, inshallah. So one final question to end this crash course related to what you have already mentioned. A 50-year-old presented with lower lobe pneumonia. Its respiratory rate is 32. Blood pressure is 88/60. What is the most appropriate next step? So first, once you see a question like this, the first thing you do is, okay, let's take it step by step. The first thing you do is curb 65. What is his curb 65? Does he have confusion? No, he does not have confusion. His blood urea nitrogen, is it mentioned? It's not mentioned, so it's 0. Respiratory rate is what? 32. This is 1. His blood pressure is below 90/60. This is 2. And he's, okay, so he has 2 out of 5. So this patient is an inpatient. This is step number 1. Step number 2 is building his protocol. So if you go back to this protocol over here, for an inpatient, you have either one of 2 scenarios, either a combination therapy of a beta-lactam plus a macrolide, or a monotherapy with a respiratory fluoroquinolone. So But if you go back to this question, which answer makes sense most? A, admitting and start amoxicillin. We cannot start only amoxicillin because he's an inpatient. You have to start amoxicillin plus something else, but it's not A. Give amoxicillin clavulanate, which is augmentin, plus azithromycin and discharge. So this would be correct if there was a discharge, because he's an inpatient. You should admit him. But amoxicillin clavulanate plus azithromycin is a beta-lactam plus a macrolide. It's good, but you shouldn't discharge. C, give azithromycin and discharge. Again, you cannot give macrolides alone. D, admit and start moxifloxacin is the correct one because moxifloxacin is the fluorocarbon. Do you guys get this question? Mumtaz. And with this, I conclude the Pharmacology CVP crash course. I hope you guys found it fun and beneficial, inshallah. If you have any questions, feel free to text me. And if you guys enjoy this sort of way I'm doing the crash courses, the pharmacology crash courses, please let me know, inshallah, for future references. And fill in this QR code as well. يعطيكم العافية. السلام عليكم.